Subscribe to our YouTube channel and press the bell icon to get the latest updates.
ThePrint OffTheCuff, presented by IIFL Wealth and Asset Management, powered by Raheja Corp, corporate partner AU Small Finance Bank, in association with global insurance brokers, airline partner SpiceJet, in alliance with Indraprastha Apollo Hospitals.
On Off the Cuff this week, a good news story, and our guest today, the gentleman, the scientist, the doctor, warrior who brought us that story. So I have Dr. Bhargava, Dr. Balram Bhargava, Director General of Indian Council of Medical Research, which is not only the premier medical research body in India, but also one of the oldest in the entire world. And he and his team have not only done a brilliant job through the pandemic, and I don't know how much you got to sleep, sir, all of you, but also it is his team in collaboration with an Indian firm, Bharat Biotech, that produced the first Indian vaccine, that is Covaxin, which has just recently got WHO approval as well. And about 14,000 have been injected already, 14 crores have been injected already, about 14 crores. So that is a real trial for any drug is when you start prescribing it at a mass level. And now 14 crores is a lot. So Dr. Bhargava, welcome to Off the Cuff, and congratulations on the book.
Thank you so much. Thank you for your kind words of introduction. I'm grateful. Thank you.
So what made you think of writing this book? It's a very pleasant book, I must say. It's a very easy read.
I'm glad you enjoyed it because we once I was in the midst of the pandemic, I was just collecting all my notes on a cardboard box, which was...
In fact, that's the most interesting part. I see some of your notes right here in the book. You know, we'll show this to you on the screen also.
Yeah. So we'd kept those notes regularly in a cardboard box, and we managed to fill up 2 of them. And then I had thought that maybe I'll be able to write something. So that and we have been writing scientific papers since I joined AIIMS. So that has been a habit to pen down what you have done.
So I see one acronym on this page scribbled here, SARI, S-A-R-I. Now that is something that we used to talk about very early on when the pandemic began, because that was, I think, when you were doing surveillance for
respiratory infections.
Respiratory infections. So tell us what it is, and tell us when did the focus shift from this to more specific stuff.
Yeah, so SARI surveillance for influenza is normally done.
Influenza-like illness.
Influenza-like illness in SARI is normally done every month by the viral research laboratories of the ICMR, and they collect data and just to get a trend of what's going on. This has been going on for many years for influenza, and then once COVID hit us on the 30th of January, we got the first case, and that young medical student who traveled all the way from Wuhan to Hong Kong to Calcutta to Bangalore and then by road to Cochin, and see how many people he must have met all during that trip. So that once that happened, we said that we need to do more surveillance and know what's going on, and that is what SARI surveillance was. What were the prevalence in who were positive or not positive of people who were presenting with respiratory illness, were they COVID positive or not. So that was the initial part of the surveillance that was started.
Because you yourself don't come from a field of virology or
public health
or basic medical. No, public health. You've said that you've been very honest to say that I am not a person from public health, but I had enough people in public health to help me, which I think is honest. Otherwise, मैंने बोला, in India, I'm sorry to say this to a doctor, everybody is an ophthalmologist in the sense of being an eye specialist. Right? I know everything, right? So he begins by saying that I am not a public health specialist, but also virology, basic medical research, sort of non-directly, how do I put it? One has to be careful. Non-therapeutic work, not treating patients, non-clinical work. That was not your field.
True, but I was involved in a lot of clinical trials, clinical studies, and bedside clinical research in the cardiac cath lab, looking at effect. I mean, answering simple, mundane question that what does the chewing tobacco do to the arteries? So I did a small study looking at.
And what does it do?
It constricts the arteries. Even chewing tobacco, no world literature on chewing tobacco and coronary arteries. Smoking is available, but we said that fine, we are taking these people for an angiogram, and they are tobacco chewers. We took ethical clearance and all and made them take tobacco on the angiography table. And then did the angiogram 15 minutes, 30 minutes, 45 minutes and found that the artery constricts. So chewing tobacco can be clot forming and block the arteries, can constrict the artery and spasm and angina, and can also promote the blockage of.
So in fact, a lot of India, particularly poorer India, there is no caution about chewing tobacco.
Yes, so I mean, we are getting diverted, but the 90% of the chewing tobacco in the world is in India, Bangladesh and Pakistan. 70% is in India. 1/3 of the population, adult population in India are tobacco consumers. And so that's a huge big problem. And I think chewing tobacco is absolute no.
In fact, I let us digress because it's a good digression. It's a good digression at a time when we see on our most popular TV channels, cricket and all, superstars promoting something which is surrogate advertising for something like this. And does that worry you?
That is very important, that we have to stay away from tobacco in any form, whether it's smoked tobacco or chewing tobacco or shisha or those new hookahs or whatever.
All equally bad.
All equally bad.
So the cardiologist, Dr. Bhargava, came out and I got curious also. Thank you very much. Those are very good words of caution. So at which point did you think, or did your colleagues think, that we could develop an Indian vaccine, and that too is Sasta, Sundar and Tikau type? So you didn't have to start with 7 years of mRNA work.
Correct. That's a very important point, because my philosophy has always been frugal innovation and low cost innovation. I want India to be self-sufficient in its own vaccines and other drugs and everything for that matter. So from that perspective, all our colleagues had discussion that what could be the simplest method of doing it. We had just isolated the virus. This was, I think, 9th March or 13th.
You said we became the fifth country in the world.
Correct. You have done your homework well. So we just isolated the virus, and we said that we need to go by the classic method of making a vaccine. Killed virus, simple, time-tested technique that we have been using in the past, and we had collaboration with Bharat Biotech for the JE virus and the Japanese encephalitis vaccine. So they had the prowess and they had the capability to develop the vaccine. We had the capabilities to characterize the vaccine, look at its properties, test it in small animals, test it in non-human primates, and then help them with the clinical trial. And that was a good private-public partnership that probably is a good example for the future generations to follow.
Yeah. So India became the fifth country, and it will be interesting for us to know who the other four were. So they were China, usual suspect, because they were the first, they should have known it. China, America, Russia and Thailand. So it wasn't one of the European countries. So that's an important highlight in the book. And we know that this is a whole killed virus vaccine is an old tried and tested method. It goes right back to the polio vaccine. So when did we think that we could try this with this wretched fellow?
No, this was, once we isolated the virus, this was March, middle of March or so. We requested our colleagues at Bharat Biotech, Dr. Krishna Ella, and I have always held him in very high esteem, being a great scientist who did his PhD in the US and then worked there for many years and then came back and set up this Bharat Biotech. And he's always been scientifically thinking, innovating, and full of energy. So from that perspective, I thought that he's probably the right man to work with. So we rang him up, we talked to him, and we said, we have the virus. Now it opens up a huge number of opportunities. We can develop a antibody test with this. We can develop monoclonal antibodies with this. And we can even develop the vaccine with this. So this is what our thinking was. And as you've already mentioned, that we had some excellent public health specialists
Will you name some?
Sure. We had Dr. Ganga Khetkar was there, Dr. Manoj Murerkar was there. During the lockdown, the fantastic thing that we had was our guest house in the Asian Games Village. We had about 40 rooms there, and we had all the scientists parked there. They spent about 3 months here from different parts of the country and were working in the headquarters as a bubble.
There is a description of that in this book as well.
and then there is Dr. Samiran Panda, who is also the director of NARI in Pune. And much of the scientists the great public health epidemiologists have done phenomenal work in the HIV.
Yeah.
And it's this HIV team that was there, where India has shown to the world how we were able to stop it. So that team is probably there. And now we need to create the next generation of that HIV team.
So when your chief virologist, that's Dr. Priya?
Chief virologist, Dr. Priya Abraham.
Priya Abraham. She saw the virus. She described it as a beautiful virus.
A pretty virus. That's
a pretty virus.
Yes.
A pretty virus. Yes. Was she amused? Was she pleased? Was she?
I think she was not happy any time between the 27th, 28th, 29th January when we were.
She was just thrilled that she got it.
Yeah. When she was testing for that virus, then it was a huge. I mean, the whole country, we had to break the news to the country that the virus has entered our shores. So she was quite nervous about that, and test again, and then isolate the virus. And then they did the electron microscopy of that virus, and they saw the picture of that virus.
Yes, in fact, there's a picture of that. It looks quite impressive. It does look pretty, actually, as long as
it does.
As long as one doesn't have it.
It does, because corona in Greek is crown, so it's like a crown.
कुदरत ने ध्यान से बनाया उसको.
फुर्सत से
बनाया. Right. So you said you chose Dr. Ella's Bharat Biotech, and one of the reasons you did that was that he has a BSL-3 lab, and you were the only ones with BSL-4 lab. So NIV had a BSL-4 lab. So please explain to illiterate people like me, what is BSL-3, what is BSL-4, and why was it so important that you went with a lab or with a vaccine manufacturer who had BSL-3 facilities?
See, there is a WHO blueprint which describes the viruses which are very deadly, with very high mortality, whether it is Nipah or whether it's Ebola or Hendra, Marburg. These are viruses which are on the WHO blueprint, and they are the deadly viruses in terms of very high mortality. And they can also be misused. So those viruses are again on the WHO blueprint that they have to be dealt with in a BSL-4 facility. And a BSL-4 facility is a maximum containment laboratory, which again probably was the vision of my predecessors, and I congratulate them for thinking about setting up a BSL-4 laboratory in the early, 2010, 2011, when it was the first in Southeast Asia.
The Chinese didn't have it.
Chinese had it in 2017. They set up the Wuhan lab was set up in 2017, and they set it up in 2010-11, and all the standard operating procedures were made at that time, and with the tremendous amount of security and fencing at that laboratory, because this is a virus which can, and that laboratory is also a repository for other viruses. All the polio viruses are kept there. We are trying to create a repository for other bacteria and fungi also in different parts of the country, in different institutes. But the viral repository is the maximum containment laboratory, the BSL-4. And for handling this virus, the lowest that you can go down is a BSL-3, because it is a highly infectious, highly contagious virus with a high mortality. So that is why we felt that if we are going to develop a vaccine, you will have to handle the live virus.
Has that incentivized other pharma companies and vaccine manufacturers also to set up BSL-3 facilities?
Oh yes. Not only other pharma companies, but other science agencies in the country and other departments are also setting up BSL-3 laboratories. In fact, we have requested one of the manufacturers to manufacture a mobile BSL-3 laboratory, and we are requested them to provide us, and hopefully by middle of next month we will have a mobile BSL-3 laboratory, and we'll station them at NIV and could drive anywhere. and one at Gorakhpur. So one for the north and one for the south, really, so that it can, and maybe one could go even to Kerala. So that will be a mobile BSL-3 laboratory.
So, Dr. Bhargava, usually we would have done this in a hall with a large audience of guests, and we would have fed them something and gave them something to drink. That we can't do. Even as you and I talk, we are talking without masks. That's why we have this partition between us. So we are not setting a bad example for anybody. Please remember that. Take all precautions. So we can't bring an audience, but I have a small audience, which is 3 of my young colleagues who cover these areas. I think you know some of them. So there is Simran Sarur, Avantika Ghosh, Mohana Basu. So one of you would like to ask a question? You have to make up for an audience of 300.
Your book has a part about rhesus macaques and how these monkeys had to be gotten from the forests in Maharashtra because we did not have any animal model, any monkeys for ourselves for this research. So, what is ICMR doing to, for the future to develop these animal models so that we are better prepared for future pandemics?
इंडिया में बंदरों की कमी तो नहीं होनी चाहिए.
No, this is absolutely a very, very important question. China is the world capital for breeding monkeys. And anything that has to be tested has to go through China. In fact, much of the vaccine animal trials in the US are done on monkeys bred in China. That is so from that perspective, we have set up a huge facility in Hyderabad called the National Animal Research Facility and Biomedical Research. This is in the Genome Valley, quite close to the BBIL, and this is on more than 100 acres of land, 18 buildings, and we will be breeding horses, monkeys, rodents, sheep, goat, everything will be bred in that, and that is just in the final phases of inauguration, because we had laid the foundation stone in 2018, and now it's ready for inauguration, hopefully end of this month or early next month. That is one facility. There is another facility outside of Bombay, just attached to the Sanjay One, which where we have built the cages for again breeding monkeys for research.
Is that a lesson from this episode?
Absolutely, it's a lesson from this, and there were some things which were already thought of but were going slow. So we're pushing the envelope.
Because in the book you say that we had no facility then to breed monkeys.
Yeah. We had to catch them from the wild, and now bred monkeys are accepted by the scientific community as been tested.
Sir, ये South Block, North Block के पीछे क्यों नहीं गए?
So they don't have any disease. So when we catch these wild monkeys,
because a lot of monkeys there, but at that point maybe they were not there.
I have a point of view regarding monkeys is that it was their land. We have encroached on their land. Right. So we have to respect them. From that perspective, I am very clear that even at All India Institute, outside many of the wards, you'll find monkeys, and we have to put grills everywhere. But look at it; it is their land which we have encroached on, and that is what we've been systematically doing, and that is why the bats have moved from the forests to the cities. That is why all these outbreaks are happening, and so we have to be sensitive to our.
So you have to breed your own now.
You have to breed your own, and then you don't need to test them for diseases.
Because this needed very speedy clearances from forest principal chief conservator for forests and others.
Absolutely, I think, and I've written it in the book that it was a well-oiled machinery. The government. I mean, I have the perception that you have as a government employee, as a doctor in All India Institute, that things will move gradually. But here we found tremendous speed this time, at least in this pandemic. The government was working very fast, and as you said, within 2 days we got permissions, and it was happening very fast.
Where are we on vaccinations for children? And also I have a second question, which is, we have passed the festive season without any major spike. So does that mean that COVID is endemic in India currently?
That's also a question from Harsha in Imperial College London, who wants to know, when can we say we have come out of the woods? As COVID seems to be endemic, at what point should we treat it as say dengue instead of an emergency?
Yeah, I think regarding your first question regarding children's vaccines, we are debating this idea. There are several systems and committees which look at it. Though not many countries have started using children's vaccine. We have done the sero survey in children where we have found a fair percentage of antibodies, more than 50% in children. So, and many countries in the European nations had not closed down schools for children. So by and large, children are protected. One, very small children are protected because they have less number of ACE receptors, so the virus does. Then slightly older children, we have seen that the antibodies have been there. So, and we are on the other side, we are seeing lots of side effects of myocarditis with the mRNA vaccine in children. We are seeing the thrombosis occurring with the AstraZeneca vaccine in children. So we have to be careful before we give it to our children. And that is why, again, I somehow feel that maybe a kill virus vaccine like Covaxin may be useful in children. And they have done some studies which are being debated by the drug controller. And hopefully, if that is approved, we should have that also for children.
And we have a lot of kill virus vaccines in our serum already.
Correct.
Various kinds.
Absolutely. Regarding your second question regarding endemicity, I think it is there is no one cutoff point that's fine. Today it's become endemic and tomorrow it will not. We have to realize that like the flu, it is endemic and it goes. This may also go in that direction. We will have to learn to live with this virus, get ourselves vaccinated, whether it's going to be or you might be lucky enough in some which way that we just find that it disappears. And that would depend on how soon and how fast we are going to vaccinate the world.
So I have a question from a fellow scientist, Vinayak Damble from Institute of Nanotechnology and Advanced Materials at BIU, Israel, who congratulates you on the book, and he says, kudos to you and your colleagues for pulling India out of the crisis, to which I second immediately and heartily. And then he goes on to say that we know that Government of India and state governments are trying to do whatever they can to provide affordable healthcare. But why isn't India promoting PPP model in healthcare? And then he goes on to say it's evident that the progress in education in the South happened with a similar approach in 1970s and 80s.
I think this is a very important topic, the PPP model for healthcare. But if you look at the pendulum as far as healthcare is concerned, when I was a medical student or a young doctor just coming out of medical school, there was no finance department in any hospital. You couldn't pay any money in the hospital.
Sir, when I was becoming a journalist, my first job in the Express in 1977, there used to be no business and economy page or desk. It was called commerce page.
True. So there was and we have seen how the NHS in the UK or the socialist healthcare in the Scandinavia has been working quite well for the last 75 years. Although they have been they have their own problems, but that is what is probably a utopian idea if we can get socialist healthcare in the country. Because once you privatize it, then a lot of decision making gets colored. So that is where it has to be a delicate balance. And I often quote the Gandhian line, there has to be a thin line between need and greed.
That's the reason you stayed on in government, no? A cardiologist of your eminence could make, I think, what you make in rupee in dollars and raised to the power 3. So we have another scientist, Sudha Bhattacharya of Ashoka University, who says that, congratulations that you've vaccinated so many people. But she says that she also doesn't like, as a scientist, that we depend so much on technologies developed overseas for biomedical innovation. And she says, are any concrete steps being taken now to promote innovation in biomedical research through, for example, increased funding and linking hospitals with university labs?
Yeah, I think very, very valid point. we have been traditionally dependent on technologies and innovation done outside of the country, and then we've been very good at making generics, but developing a new molecule, for example, for any drug, we are not the best. We need to develop that. So, and we need to change the mindset also that developing a new molecule or a new drug is going to be.
Because you say in the book that most of our fame is in generics because we can produce it cheaply and on scale.
Exactly. But more important, if we have to go in that direction, we have to. For new drug discovery, new molecules, they are going to be expensive. The mindset has to be there within, not only in the government, also in the private sector, that they're going to be expensive to produce new drugs. And we need to invest more. The government is investing a lot more. I mean, if you look at the Indian our council, our budget has gone up, not because of the pandemic, but because the government is thinking of becoming self-sufficient in many which way, and many agencies are being funded a lot. More importantly, the private-public partnerships are important because the public funding can de-risk the private players. If they want to put in certain funds for do the initial work, then the partnership will de-risk it. So that is important.
I told you 3 of you have to make up for 300.
I wanted to know about what you think of this debate around the origins of COVID and also where you stand. Do you think that it could be an outcome of gain-of-function research, or do you lean more towards it being a zoonotic?
See, one thing is very clear, that the bats are reservoirs for these viruses. Yes. That is very clear, and we've done several studies around Pune and in the north.
But the world has still not found the bat with this carrying this virus.
Absolutely.
That's odd.
That is odd, and we also know that there is a gain-of-function research being funded by the US in many parts of the world. Having said that, it is very difficult for me to pinpoint whether it's a zoonotic origin or a lab origin. To be honest with you, I cannot give an answer.
So the question is कि what are the odds कि जो pretty virus है ये कुदरत ने बनाया कि इंसान ने बनाया?
बनाया तो कुदरत ने ही है. इंसान ने इसको कुछ मॉडिफाई किया कि नहीं मॉडिफाई किया, ये सोचने वाली बात है.
वो आपको एक गाना याद है, आपकी हमारी एज का ही है, खुदा भी आसमां से जब जमीन पर देखता होगा, मेरे महबूब को किसने बनाया सोचता होगा, है ना? तो वायरस को भी ये सोचता होगा. But there could be gain of function in this. There could be some human intervention.
There could be some human intervention which we need to, I mean, I don't think whether we will be able to answer this, but gain of function research can be useful at some situations, but here I don't think.
But do you support a stronger investigation into the origins of the virus, or do you think we should just move on?
To be honest with you, I always tell my colleagues here also that Second World War philosophy was keep calm and carry on. That works well in life. That works very well.
So were there moments in this vaccine development? Were there moments of high and moments of lows?
Yeah, the moments of highs were yes. So I'll give you the moments of low first. Moments of low was we needed the monkeys, we didn't have them. Moments of low was we had to do bronchoscopy of those monkeys and give them the virus inside them. We didn't have a scientist in Pune at that point in time, or a trained respiratory physician who could do that. So we took help from CTC Pune. And we had one pulmonologist here at the headquarters. We flew him through an IIF plane during the lockdown, and he went there and he was able to do the bronchoscopy of those monkeys.
So there was an IIF plane arranged only to fly your pulmonologist from where to Pune?
Yeah. This
to give bronchoscopy to monkeys?
To monkeys, absolutely. And then the low was whether these monkeys will respond or not respond. And the high was when we got the results of these monkeys. That was the high point that the vaccine is working. Now what we did was we vaccinated the monkeys, and then we took them to the maximum containment laboratory, and we gave them the virus with a bronchoscope. in the third generation of the bronchi. That is real deep inside the lungs. We gave them the actual virus. And then every day we collected their samples with the bronchoscope. And sterile, the virus had not grown in any of the samples or in the majority of the samples. And that was really the high point that the vaccine is working. And I think that was the turning point for us to go to humans and then look at what's going on.
Rahul Kulkarni, again a scientist, Institute of Chemical Technology, Bombay, Mumbai. More than 2/3 of the population has antibodies against COVID, most of which comes from natural immunity. Can we see a resurgence of COVID cases as natural immunity wanes and vaccination figures stagnate after a point?
Difficult to answer just now, to be honest with you, because we do not know how long the immunity lasts. We know it does last up to 1 year. We started vaccinating only after the 16th of January. That is one thing. And antibodies after infection do persist. One infection is equal to 1 dose of a vaccination. So from that perspective, it's a mix and match of situations, and we really do not know where we are heading.
You also mentioned your own days in isolation in your own hospital when you got COVID.
True, and that was worrisome, because once you live how a patient is dealing with this was tough. The stigma attached to it, the isolation, the cold weather. I mean, it was, although the places December, and then you are absolutely alone in a hospital for at least 7-8 days. It is, and all you have is your mobile phone and your television. I do not know. I mean, it was tough. It was tough.
And you are a doctor. Everybody else.
I did carry one PG Woodhouse with me.
I bet you remember it by heart by now. It was good reading. Maybe a whole collection would have helped. Now, there's a tough question, a trick question from Dr. Maulik Bakshi, Fraser Health Authority, Canada, who says ICMR is primarily a research body. Why is it issuing clinical treatment guidelines and doing, I don't understand it, and he says, and doing epistemic trespassing?
Okay, good point. The ICMR was not supposed to be doing testing. We had only one laboratory, the NIV, which was doing testing. We had a viral research laboratory network in the country for helping the NCDC for viral diagnostics. So, as a country, we had to stand up at that point in time. We set up the laboratories. Once we set up the laboratories, there was a lot of credibility in society, and therefore we created the National Task Force with the Ministry of Health. And that National Task Force was the one which was giving the guidelines, ICMR and the Ministry of Health together.
So he's asking a follow-up question, which would have been my question also, but the guest is always first. He says, also, if you issue clinical guidance, why was the ICMR slow to accept the scientific evidence that both hydroxychloroquine and ivermectin were ineffective? It can be argued that ICMR's inability to take a science-based clear stand has led to avoidable drug toxicities that contributed to hospitalizations and possibly deaths.
Well, hydroxychloroquine still is an unanswered question. Hydroxychloroquine was given to a lot of healthcare workers. There is a full group of people who think that it still works for early disease. Group of people think that it does not work. No one says that it is harmful. So that's, I'll leave it there.
So in fact, when your guidelines came out, for the first several weeks, even I popped them.
Yeah, even I had them.
Yes, but so you think that is not yet settled? Because I saw your papers in our own journal,
Yeah.
which showed, but those were empirical from your healthcare work.
Paper, there is lab evidence, it's antiviral, there is good papers published in big journals that it has got antiviral properties, but still remains unanswered.
Do you have any follow-up on that?
I have a follow-up on plasma. Your own study on plasma showed that it does not work, yet we persisted with plasma therapy for quite a while after that, and even now in scientific literature. This morning there was a study in NEJM which talked about use of plasma early on in COVID. What is this optimism about plasma?
So, see, plasma therapy has been used for nearly 100 years now for various viral, and obviously mostly empirically, mostly without much evidence. This study, the Placid study that we were able to conduct, we were really concerned about the ethical issues of the use of plasma as well as the effectiveness and the questionable effectiveness of plasma. So we rapidly did that study during a lockdown by democratizing research and utilizing hospitals through VC in a big way. And that was a really well conducted study, scientifically robust. And we were clearly able to demonstrate it. It got published the study was started somewhere in May, June, and we completed it in July, August, and published in October. So we did give those, and they were released, everyone knew about them. But again, it is a gradual process for people to accept. It's again not so deterministic. Human biology, you have to remember that it's a gradual process. You just can't say today this thing is good and tomorrow it is bad. It has to be backed by evidence. There were some papers which are really still supporting it. So human biology can never be deterministic. It is a stochastic science. And therefore, evidence keeps coming up. Yes, it is working, not working. But once we got this randomized trial, which is the highest level of evidence, which clearly showed that it is not working, we were able to convince our experts to remove it from the guidelines.
In fact, you mentioned that in the book. Also your first trial, which was done very quickly. Now, ivermectin, is that chapter closed now? It doesn't work?
See, now here there is for example, Regeneron, which was given to Donald Trump.
Yes.
Now, some things will work when they are given at the right time. If you are able to diagnose or you have exposure and you're going to become positive, at that point in time, if you give Regeneron, it may work. If it is slightly late by 2 days, it is not going to work. Now, those kind of things are, again, human biology, when you are going to give it. So the timing is very important, and it's very difficult. Testing itself takes 24 hours. Yeah. Getting a result takes so much time. So by that time, you've missed the window in many of these newer drugs. Many of these newer drugs, you will miss the window.
Yeah. So one more scientist, Dr. Vimla Veeraraghavan, Emeritus Professor at APJ Satya University. Countries like Russia and even Israel are experiencing increased number of corona infections now. People in India, by and large, behave as if everything is back to normal. As a scientist, what is your opinion and reaction to people's relaxed behavior in the country?
I am very clear that these vaccines or these infections are disease-modifying vaccines. They do not prevent the disease. So you will not get severe disease or hospitalizations in majority of the patients, but they will not prevent the infection. So we have to continue to be careful, and we may continue with this for
yes, right.
more time.
That's why at ThePrint we carry these with us. We have a bunch of these. These cost very little, but these are lifesavers. And also these set a good example. So you people don't think, forget me, you don't think that Dr. Bhargava is being reckless.
No, and all your reporters are wearing the mask, which I think has been tremendous. And here again, I would like to add one more point, that I've been seeing Avantika at the PIB every day, I mean every Tuesday or Thursday whenever it was held. And the work that they have done and the responsible reporting that they have done, kudos to you people. That's been fantastic.
Absolutely. In fact,
I mean, this is a country, there's no vaccine hesitancy.
Right.
Incredible. And that is because of the way you've been reporting.
Incredible. Look at America. It is the most, when it comes to science, it's the most illiterate country in the world. But you've seen those surveys in America where 40% Americans or something like that say Darwin was a nut. Right. So America is unique.
It is unique. It has. They have good science there.
No, they have good science, but they also have this disinformation and all this stuff, and class action suits. So the fear of God. I have again a doctor, Dr. Shiv Narayan Kalia, TriStar Hospital. The antibodies have almost become zero after 6 months of second dose. In his case, when should the third or booster be taken? Will this be a regular or annual event now? Because Britain now, with AstraZeneca also, is now insisting on a booster for everybody above 40 years of age, I think.
I think Britain and US are probably and Israel are probably the only few countries who have recommended booster dose for elderly, for people with immunocompromised status. Having said that, we have antibodies, we have cellular immunity, we have T cell immunity, we have mucosal immunity. Many of them cannot be measured. So from that perspective, I don't think we are ready yet as a nation. But more importantly, there is an ethical issue where we need to be very clear that we need to get the entire adult population fully vaccinated. That means both doses should be given. And you have seen the recent statement of the WHO Secretary General, where he has really, really hammered the booster dose in a big way.
Minhaj Ahmad Ansari from Larsen and Toubro. How challenging was it to fight the unprecedented amount of misinformation about COVID? So please read the book. He lists, I think, 582 therapies that were referred to ICMR for testing. What was the most interesting therapy? Besides chewing ginger, maybe.
Something like those. Getting your ear pierced, or doing a havan, or using some stone which is going to give some. Wearing a locket of a stone or something. So those are the ones which were quite interesting.
So how challenging was it?
That was tough because many of them were backed by big people, and they wanted it tested. They wanted it tested fast. They wanted it to test positive also, that they are working. So those are the 3 or 4 challenges which were tough. But fortunately, we were able to create a consortium of several institutes within the country for testing different types of therapies, and they did perform.
But many theories came and disappeared. Somebody said that you sit in the sun, so vitamin D will help, right? Then that, in hot climates it will die. There were some preprint suggesting that. Then that Indians have innate immunity. That also got defeated the second time. So how did you navigate through those?
See, personally, as an organization, we always sat down. Even during the lockdown, we used to discuss quite often, regularly, morning, evening, of what literature has come in, what is the biological plausibility of this, and what we should put in the dustbin right away, what we should keep on the table for some time, and even one point you missed about the surfaces, whether that also kept changing. That also kept changing, And now more and more evidence is coming that surfaces probably do not transmit the virus.
Yes.
So
big research came out of Germany first. Door handles, etc. didn't have the virus.
True. So it's been an evolving time for not only the scientific community but for everyone. The whole world has been learning.
Yeah. Dr. Ram Nair, Northwest Regional Hospital at Burnie, Tasmania, Australia. You have done an excellent job under the circumstances and the government should be congratulated. But then he goes on to ask, could you have started this intense campaign earlier? Why didn't you respond positively when Pfizer and Moderna offered to provide us vaccines initially? We would then have had abundant supply early enough to slow the second wave.
Regarding Pfizer and Moderna, they were new vaccines. They were not, I don't think they were able to supply rather than we receiving them. They were able to supply from January of 2022 or maybe 1 or 2 months here and there. That was too late, and we were already working on our vaccines. We already scaled up our vaccines, and we believed in our science, and that stood well.
So I think as we are coming to the conclusion of this, there is a question from an Indian Army officer, Neeraj Pant, who says in December 2020, in a presser, you and your health secretary conveyed that there are no plans to vaccinate the entire population. Do we make out that it is the second wave that led the government doing the course correction in April-May 2021?
See, the entire population means 130 crores. We are today even talking about the entire adult population, which is about 94 crores. And that is what we are doing. So you can read the nuances between the two.
Yeah, so Uddhav Pandit, was the delay in obtaining approval for Covaxin a conspiracy by MNC pharmaceutical companies? I presume he's talking about WHO approval.
I don't believe in these conspiracy theories as at large. I mean, I again hammer on the same message: keep calm and carry on. Keep doing your work. People will have theories. People will have their hypotheses. They keep coming and keep going. As you yourself have mentioned, that so many hypotheses came regarding the virus, and many of them were junked. Many of them did.
Yeah. So, do you agree with Dr. Ella saying that WHO asked them many more questions than he would have asked other vaccines?
I don't agree with that, but you have to remember that vaccination, evaluation, emergency use licensing would vary with the state of the pandemic, the state of the preparedness, the state of the vaccination, and that is a moving target. Although they have a set questions which they ask, and many of them would depend on the experts if they want to ask more questions. So that varies. And then they have several committees. They have the SAGE, they have the technical committee, and then they have the independent.
Because if I remember correctly, unless it's happened over the last few days, the Russian Sputnik has still not been approved by WHO. No. Yeah. Nearly 80 countries accepted, but not WHO. And that's approved in India as well. Now, last two questions. Sandhya Ramesh, our science editor, this is question sort of that should catch you. Is there a rise in cardiac cases among younger men in the country? What should the appropriate response be? Should hospitals be testing more? And there I will come to the next question. Some eminent cardiac surgeons have said that people should have routine CTs after the age of 40.
Yeah, this is worrisome because I have clearly said, and this is clearly mentioned, that there is no, and I would underline no with capital, no benefit of doing unnecessary tests. We have to look at the risk factors. We have to look at the blood sugar, diabetes, hypertension, cholesterol, obesity, and exercise, and tobacco. So at the age of 25, we should know our blood sugar level, we should know our blood pressure level, we should know our cholesterol number, we should know our weight number, we should stay away from tobacco, and we should not be, we should know our weight number, so we should not be obese. And so if you have these risk factors taken care of, you are pretty much fine till you have. Asymptomatic people should not be tested beyond these tests that I have.
Yeah. And is there a rise in cardiac disease among younger men in India?
There are more younger men in India than anywhere else in the world. So
there's more of everything in India. Yeah. YP Rajesh, our managing editor, what is the biggest lesson public health officials have learned from the pandemic so far?
I think what we have learned from this pandemic, and as public health specialist, I'm not a public health specialist, but the government, the world needs to invest more on public health, clearly. We need to protect our ecology, we need to protect our environment, and we need to work together. What I have seen, at least in my organization, 2 scientists have started working together, 2 laboratories have started working together, 2 institutes have started working together, 2 ministries are working together, and now it has been a whole of government approach, and now several countries are working together. So that is probably the answer.
Do you have any regrets of anything that might have been done or might not have been done through this journey of nearly 20 months now?
I think the major regret, I could have been a better communicator. And that is probably my weakness. I'm not a good communicator, so that could be.
No, I think you're doing all right now.
The training provided by Abantika and your colleagues that over the PIBs for so many weeks. But that is probably one thing could have been better communicated.
So if I may ask you a trick question, that letter you wrote, setting a deadline for the vaccine, 15th August of 2020, was that a misstep? Would you rather not have written it?
See, the letter was
You know it was well-intentioned.
Yeah, it was well-intentioned to cut the red tape. The language could have been slightly different, clearly.
Because it did look like that the highest scientific authority in the country wanted a vaccine by a deadline, and deadline by a time through which no clinical trials could be done.
What happens is that these organizations are big organizations. Now, this is a 111-year-old organization. Now, to move this whole big ship, you need to what they call give a little shock immediately. So that was probably what it was meant to be.
पंजाबी में कहते हैं हला शेरी दे दो.
So that was what was intended to. Language could have been different.
So it was then construed to mean that it's an interference with trial processes.
Not at all. Not at all.
It wasn't there at all.
And you can look at the track record. Look at those 3 volumes lying there. They are the 250 papers published in scientific, contributed to world literature. All documented. Whatever we have done, scientifically peer-reviewed publication.
These are all your papers, isn't it?
These are all ICMR papers, yeah.
My God. I think I should take these home to the gym. Fantastic. So how do we continue this forward now? All the new infrastructure you've built or the new lessons you've learned, because more pandemics will come.
Yeah, I think as we speak, I think I have told all my scientists, and I've requested them as well, that this is like a football match. Go anticipate where the ball is going to, not where the ball is. Right now the ball is all at COVID. We have done enough, we are doing still COVID. Anticipate where the ball is going to, and that is tuberculosis. We have to focus on tuberculosis, and that is still a huge big problem, and I think that is the next frontier that we have to work on.
Abandika, you are a tuberculosis specialist in journalism for a long time. You have a question to that, and then we'll wind up then.
We have lost quite a bit of time in tuberculosis active case finding and screening and all of that because of COVID. How are we planning to make up for lost ground?
That is definitely a problem, but then now for diagnosis, we have new technologies, we have newer testing methods, we have quicker methods, we have availability of a large number of methods. For example, TrueNat is available now in abundance. So the COVID also created a lot of infrastructure which can be repurposed for tuberculosis. And that is probably the silver lining.
I think we've taken a lot of your time and you have a lot more to do. So we'll let you go. Congratulations again. People, buy this book. It's very, very easy reading and you will learn a lot from it. And it's also inspirational. And the best thing about the book is that it mentions a lot of names that we've never heard of. These are scientists at the many labs, young, old, other people who got involved. And you can see what a big effort it was. It tells us that when India puts its heads together in a crisis, India delivers like no other country can. And we know that after wars, there are gallantry awards given to soldiers. This has been like a war. And awards are given when the war is over. So I don't think we can declare the war is over. But when the war is over, I hope there is a series of the equivalent of gallantry awards for doctors who've done it. And you mentioned that a lot of your scientists are women.
Oh, absolutely. And they are very hardworking, very, very hardworking, very committed. And there is a system in place in this organization. And they work once the command comes, they get onto it. So that is very important. And I found that very useful because it's only I've seen it in organizations like the army or in the medical profession. But even here, I'm finding it among scientists that they work with a command.
Because you mentioned that your chief virologist would make a very good STEM ambassador for women in particular. So put her in front of the camera a bit more often because we need more people studying science in the country. So once again, whatever this wretched virus may have done, it's given a shot in the arm to medical research and science.
Absolutely, and I think we have to look at the brighter side of this now, particularly when it's on the way down. We have to look at what infrastructure we have been able to create, what trainings that we have been able to provide, what funds that have been pledged by the government and private organizations for healthcare. So it's from that perspective, it's been an opportunity, I would say.
Well, congratulations once again for this and for all the great stuff you've done, and good luck to you, and hopefully by the time we have our next conversation, we'll not need to have this 20 millimeters of plastic between us.
Thank you so much. Thank you so very much. Thank you.
Wealth and Asset Management, powered by Raheja Corp, corporate partner AU Small Finance Bank, in association with global insurance brokers, airline partner SpiceJet, in alliance with Indraprastha Apollo Hospitals.